So I'm going to be covering new treatments for hammertoes and hammertoe implants. So a hammertoe is caused by an imbalance in the muscles, tendons, and ligaments that usually hold the toe straight. Hammertoes have been linked to certain types of shoes, and the shoes that can cause this kind of disorder are high-heeled shoes or footwear that is too tight in the toe box, causing crowding of the toes into a space where they can't lie flat. The curled toe position caused by the tight shoe may persist when you are barefoot. Hammer toes can also be caused by trauma. Any kind of injury where you stub, jam, or break a toe can make it more likely for the digit to develop into a hammer toe. Another reason is an imbalance in the toe muscles. This imbalance can lead to instability, which can cause the toe to contract. There are 3 different mechanisms by which the muscle imbalance can occur: flexor stabilization, flexor substitution, and extensor substitution. Flexor stabilization occurs in the feet that are excessively pronated. The subtalar joint pronation allows hypermobility and unlocking of the mid-tarsal joint, leading to hypermobility of the forefoot. The flexors fire earlier and longer than normal in an attempt to stabilize the forefoot. The flexors overpower the interosseous muscles and cause digital hammering. There's also a possible associated adductor varus of the 4th and 5th toes because of the quadratus plantae, because the quadratus plantae loses its mechanical advantage. So flexor substitution occurs when with the weak triceps surae. The deep posterior leg and lateral leg muscles try to compensate for the lack of plantar flexion, and in doing so, they create a high arched supinated foot and contract the digits. There is usually no adductor varus deformity of the digits. So extensor substitution is where the extensor muscles normally contract to dorsiflex the ankle to allow the foot to clear the ground during the swing phase. With extensor substitution, the extensors gain a mechanical advantage over the lumbricals, and the extensors will contract the MPJs. There is normally no adductor varus deformity. So causes of this will include anything that will give the extensors a mechanical advantage over the lumbricals. So there are certain factors that will increase the risk of getting a hammer toe. These factors are age, sex, toe length, and certain diseases. The patient's risks of getting a hammer toe will increase as their age increases. As for sex of the patient, women are much more likely to develop a hammer toe or a mallet toe than men. If the second toe is longer than the big toe, it also puts you at a risk of getting a hammer toe. As for the diseases that can increase your chances of getting a hammer toe, arthritis and diabetes are the big ones. They make you more prone to hammer toes, and heredity might also play a role. So you can avoid many foot, heel, and ankle problems just by simply choosing shoes that fit properly. When buying shoes, you should avoid shoes with pointed toes because these will cram your toes into a small space. Lower heels will also decrease pressures that you're putting on your toes and will help you to avoid back problems as another positive. Also, adjustable shoes with laces or straps will be roomier for your toes. By the end of the day, your feet are going to swell, so buying the size that fits you will help to prevent the smaller spaces that predispose you to the hammering of the digits. Before trying surgery, you should first try a conservative treatment. This consists of certain exercises and switching to shoes that have proper space, manual stretching, custom-made orthotics to stop the hammering from worsening, corn pads to stop callus formation, or foot straps to relieve some painful symptoms, or cortisone injections to help relieve some of the pain. One conservative treatment just isn't cutting it. The patient and doctor may decide to move on to a surgical correction of the issue. The old procedure that is still used is a PIPJ arthrodesis with K-wire fixation. This procedure has a decent success rate, but it has complications. Some of these complications are pin tract infections, pin migration, hardware failure, loss of correction, non-union, malunion, recurrence of the deformity, and amputation. So the sequential release of the soft tissue for a hammer toe consists of 5 steps. First, you would release the extensor expansion, then you would perform a tenotomy or lengthening of the extensor digitorum longus or the extensor digitorum brevis. Then you would perform a transverse MPJ capsulotomy. Then you would release the collateral ligaments, and finally you would release the plantar plate using the metatarsal or the McGlamory scoop. So the newer procedure that's being utilized more often when conservative treatment fails is the joint implant arthrodesis. These new implants offer controlled positioning, rotational stability, and dynamic compression across the joints. The implants have there are many different options for implantation. You can either have 10 degrees of dorsiflexion or 0 degrees in just a straight implant. Most of the implants change their shape depending on the temperature that they are exposed to. So why should an implant be used over other procedures? Implants are used when an arthrodesis is indicated. Using an implant over the K-wire fixation will decrease the fusion time, and there will be a decrease in infection because there will not be an open wound where the K-wire is entering the skin. The implants are much more stable in K-wire fixation also. So in order to perform the procedure, a linear or a transverse incision must be made over the metatarsal head. The toe is plantar flexed and the head of the proximal phalanx can be resected about 2 to 3 millimeters. A drill can be utilized in the proximal phalanx, and it should be used in order to make passage for the implant to enter into. Corresponding broaches should be used to size the hole that we're using to put the implant into as well. A stop drill can be used in order to prepare the more distal phalanx. A drill should also be utilized after that in order to prepare for the implant. You should use the broach for sizing on this side too. So there are certain tools and special forceps that need to be used in order to grip the implant and place it into the more proximal of the 2 holes that you have drilled. After the proximal head of the implants is placed, then the distal head can be placed. Some implants need cement inside and some expand when exposed to body heat. So then the proximal and the distal aspects are pushed together and the toe is held into place until the implant is expanded or the cement is dried. If the toe is still not flat, a wheel osteotomy can be performed on the distal metatarsal neck. So just going into a couple different devices that can be used. The Smart Toe 2 by Stryker is self-expanding, and once it's inserted, then it expands once it's exposed to the body heat. It can be used in the proximal IPJ or the distal IPJ, and it offers rotational stability and compression across the joint line, while avoiding potential complications experienced with K-wire, such as pinch tract infection and postoperative exposure, as I mentioned earlier. It has been clinically documented with fusion rates over 90%, which is twice the fusion rate of K-wires. So this implant is made out of silicone and it has no hinge. It has a cylindrical midsection that comes in 2 sizes and preserves the length of the digit. They also have a cylindrical stem. This type of implant is indicated for the PIPJ and it is produced by Wright Medical Technology Incorporated. So the Sagarthal Hammertoe implant prosthesis, otherwise known as the SHIP, is also a hingeless silicone implant. This implant has a rectangular tapered stem instead of the cylindrical one. It has tapered rectangular midsection and the narrow end goes distally. This implant is also indicated for the PIPJ. So this is another implant done by Sagarthal Incorporated, and it is also a hingeless silicone implant. This one is indicated for the PIPJ or the DIPJ. This implant is also indicated for the PIPJ or the DIPJ, and it is also made out of silicone. It provides a flexible, stable joint, and it maintains the length of the digit. With this implant, there are varying levels of stiffness and flexibility depending on how thick of an implant that you want. The thicker you go, the less flexibility you're going to have. So it depends on your patient type for how thick you want your implant to be. The cannulated titanium implant can be used for any of the lesser toes and can be used along with the K-wire for ideal placement of the insert. So the case study that I chose is to review the cannulated titanium implant from the previous slide. The objective of the study was to demonstrate the outcome using the Trillant 2-step Hammertoe implant for fusions of the IPJ of the lesser toes and benefits over other methods of fixation. There was a total of 20 patient charts that were reviewed and a total of 22 surgical encounters on 25 feet. There were 2 patients that had surgery on the contralateral side and 3 patients had bilateral surgeries performed adding up to 51 toes in total. So the procedure was performed on the distal IPJ as well as the PIPJ. The surgical technique consisted of the fusion site being prepared by either using a saw to create a flat end-to-end cuts, or it utilized cortical reamers. So then the K-wire is inserted through the middle and distal phalanx and out through the distal tuft of the toe until only a small portion of the wire is exposed to the IPJ. The proximal phalanx is then drilled out and the appropriate length fixture is driven into the middle phalanx until it's flush with the cortex of the bone, with only the spade fins pointed dorsally. So the implant is then guided into the proximal phalanx and the guide wire is advanced. 44 of the 51 toes had satisfactory union and deformity on the final post-op follow-up. 4 toes had asymptomatic non-union with satisfactory clinical correction. 1 toe had a non-union with deformity but did not require surgical revision. And so only 2 toes out of the original 51 needed to return to the OR for removal of the implant. 1 of them was for infection and 1 was for displacement of the implant. So the conclusion of the study yielded satisfactory results overall. The only limitation and downside to the implants was that they had the inability to correct and stabilize both the PIPJ and the DIPJ. They also have the inability to maintain temporary correction of the MPJ or the DIPJ while the soft tissue is initially healing. There was also displacement of the implant noted as a potential complication, where the spade would rotate away from the dorsal aspect of the toe. One of these setbacks, or other than these setbacks, there were great results with this implant if you're a skilled enough surgeon to properly insert it. And these are my sources.